My name is Nick Shida. I'm an abdominal radiologist at the University of Ottawa. This is my talk on CT and MRI of small solid renal masses. I have no disclosures for the talk. I'll present a brief outline of what we'll cover during the lecture. We'll discuss the epidemiology of solid and cystic renal masses. We'll spend quite a bit of time discussing the CT and MRI techniques and how to optimize both to maximize accuracy for characterization of renal masses. And then we'll conclude the talk reviewing the ability to diagnose and subtype solid renal masses and also to potentially grade renal cell carcinomas with imaging. So beginning with epidemiology of renal masses, incidentally discovered renal masses are very common. The number varies, but there are some studies which have shown that patients undergoing CT may have an incidental renal mass in up to 40% of cases. In most cases, those are benign cysts, but a significant proportion of incidentally discovered renal lesions are also solid masses. And renal cell carcinoma now most commonly presents as an incidentally discovered renal mass. Most, approximately 80% of solid renal masses are malignant. However, in large surgical series evaluating consecutive cases of less than 4 centimeters solid renal masses that underwent surgery, approximately 1/5 are benign, chiefly oncocytomas and fat-poor or minimal fat angiomyolipomas. The incidence of benign disease increases even more in tumors that are less than 2 centimeters in size, whereas malignancy is overwhelmingly more likely in tumors greater than 4 centimeters. So for this talk, we'll concentrate mainly on tumors that are less than 4 centimeters in size. Among the 80% of malignant solid renal masses less than 4 centimeters, clear cell renal cell carcinoma is by far the most common and is also the most aggressive, with the remaining renal cell carcinomas in this group composed primarily of papillary renal cell carcinoma and less commonly Chromophobe RCC. There are other rare renal malignancies, though these aggressive diseases such as medullary or anaplastic renal cell carcinoma are much less commonly seen at small sizes. In the 20% of benign solid renal masses, as I mentioned earlier, they are split predominantly equally into oncocytomas and fat-poor AML. Oncocytomas can be multiple and can be associated with older age, whereas fat-poor AML typically are quite small and smaller than renal cell carcinoma and oncocytomas. They're incidentally discovered, and unlike their classic counterparts, they're not associated with bleeding complications, and they tend to occur in younger and middle-aged female patients. So moving on to CT and MRI technique. The fundamental requirement of a renal protocol CT or MRI is to characterize the presence or absence of enhancement. In order to do that, you need to know what the thresholds are to diagnose enhancement confidently with both CT and MRI. On CT, we primarily rely on attenuation change comparing unenhanced and post-contrast enhanced images. And the number that's ingrained in the literature is an attenuation difference of greater than or equal to 20 Hounsfield units. Although newer literature evaluating multi-detector CT has proposed that 15 Hounsfield unit may be a more reliable threshold for determination of enhancement. In our practice, we continue to use 20 Hounsfield units as a definitive threshold for enhancement, and we consider masses that enhance between 10 and 20 HU indeterminate, whereas those that show an attenuation change of less than 10 Hounsfield unit as having no enhancement. Enhancement can be judged on MRI visually or quantitatively. The majority of clinical practices, including our own, use a visual signal intensity change analysis comparing pre- and post-contrast images, and in the context of T1 hyperintense masses, rely on subtraction images. Although signal intensity thresholds have been proposed and validated, and a 15% or more signal intensity change comparing pre- and post-contrast images is a reliable threshold for documentation of enhancement. In terms of a comprehensive CT renal mass protocol, the two basic requirements are an unenhanced CT and a nephrographic phase CT, performed using the same technique, i.e. the same KVP, to allow for a reliable comparison of Hounsfield units between phases. It is also important to scan at conventional 120 kVp settings and not use low kVp imaging for renal mass CT, particularly when using Hounsfield unit measurements, as these become somewhat unreliable at lower kVp imaging. The corticomedullary phase is actually considered an optional component of a dedicated renal mass protocol CT, though it does add significant value in terms of characterization of renal masses and the renal vasculature. And the urographic phase can also be added to a renal mass protocol CT, primarily for further characterization of renal masses and their relationship to the collecting system. Dual energy CT has been applied and validated for renal mass evaluation. Advantages of dual energy CT are that it could further characterize indeterminate masses detected at single phase enhanced CT. It's better correcting beam hardening artifact, so it could potentially decrease pseudoenhancement in small renal lesions, and it may be more sensitive to iodine. Although there are a whole host of disadvantages with dual energy CT, primarily relating to its relative novelty and lack of standardization between vendors, systems, and institutions. Here's an example of how dual energy CT can help in the characterization of an indeterminate hyperattenuating lesion detected at single phase portal venous phase enhanced CT. We can see that in the interpolar region of the left kidney, there's a 41 Hounsfield unit homogeneous lesion, which could be a hyperdense cyst or a renal cell carcinoma. And typically what we would need to do is call the patient back for a dedicated renal mass CT, MRI, or ultrasound. In this case, the patient happened to have been imaged with dual energy CT, and we can see that on the iodine overlay image, there is no iodine within the lesion, which we confidently diagnosed as a hyperdense cyst and which was confirmed at a subsequent targeted ultrasound. Here's another example of a patient who underwent MRI for characterization of an indeterminate lesion on ultrasound. We can see that there is a T2 hypointense mass in the interpolar region of the left kidney, which has marked restricted diffusion. The lesion is slightly hyperintense on T1, and on the subtraction image, it appears to be enhancing, although we can see that there's significant motion artifact which compromises the subtraction. The patient underwent a renal mass protocol CT, which shows a 17 Hounsfield unit increase in attenuation, which is in the indeterminate range. This happened to be a dual energy CT, and we can see that on the iodine overlay image, there's no iodine within the lesion. So we favored, though we could not reliably diagnose, a hyperdense cyst, and this lesion remains stable on follow-up for 3 years. Other potential applications of dual energy CT are a slightly higher sensitivity for iodine. As we can see on the top panel, we have a low enhancing papillary renal cell carcinoma, which does not enhance by greater than 20 Hounsfield units, but which shows a significant amount of iodine on the iodine overlay image, both subjectively and quantitatively, and a diagnosis of papillary RCC was confirmed at biopsy. Other authors have investigated the ability of iodine overlay images and iodine concentration to differentiate between clear cell and papillary renal cell carcinoma, and we can see on the bottom panel an avidly enhancing mass in the right kidney, which shows a very high iodine concentration, much higher than on the top panel, and this was diagnosed as a clear cell renal cell carcinoma after partial nephrectomy. One pitfall with dual energy CT is to not rely exclusively on the iodine overlay image to diagnose enhancement, because some hyperattenuating cysts may appear to contain iodine on the iodine overlay image. We can see here there's a patient who underwent an ultrasound showing an indeterminate nodule in the interpolar region of the left kidney. The patient underwent a dual energy CT renal mass protocol, and I've provided the iodine overlay image, which shows hyperdensity or increased uptake of iodine apparently within the lesion, which could be diagnosed as an enhancing renal cell carcinoma or other solid lesion. But we can see that when we review the trace images, when we compare the true unenhanced CT to the true portal venous phase enhanced CT, there is no enhancement within the lesion, which is greater than 70 Hounsfield unit at unenhanced CT. So this is an example of a pitfall of dual energy CT, which may falsely characterize hyperattenuating cysts as enhancing on iodine overlay images. Moving on to MRI, I've provided a basic MRI protocol that we use at our institution, and this is pretty much standardized across most institutions doing renal mass imaging with MRI. One thing that we do slightly different at our institution is we include rescue sequences for patients who may not be able to suspend respiration and in whom post-processing subtraction images may be compromised. Here is an example of an older patient who had an indeterminate lesion in the right kidney at single-phase enhanced CT, measuring 32 Hounsfield units. An MRI was performed, which was significantly degraded by motion artifact. We can see that on the axial T2 weighted image and on the post-contrast image, the lesion is blurred by breathing. The breath hold for this patient using conventional post-contrast images was 21 seconds, and by increasing the parallel imaging factor, we were able to reduce the breath hold to 7 seconds, which the patient was able to comply with in terms of their breath hold capability, and that cleared up the lesion as a non-enhancing cyst. An alternative to decreasing the breath hold with parallel imaging is to acquire enhanced images using free breathing techniques, which are available on both of the major vendors. We can see here in the top panel a patient that has a enhancing renal mass in the renal sinus of the left kidney, but also an indeterminate lesion in the interpolar region of the cortex, denoted by the arrow. When we compare the pre and post-contrast images and the subtraction, there is a significant amount of motion limiting assessment of the lesion. The bottom panel represents a free breathing technique which was gated using navigator acquisition, which has significantly improved image quality and co-registration between the pre and post-contrast enhanced image sets. And on the subtraction image, we're able to diagnose that lesion as a T1 hyperintense hemorrhagic or proteinaceous cyst. In terms of comparing CT and MRI, CT has a slightly higher ACR appropriateness criteria rating compared to MRI, which relates primarily to a very good accuracy, cheaper cost, and more readily available technique compared to MRI. One problem with CT is that it could result in pseudoenhancement. It may incorrectly characterize low-enhancing papillary renal cell carcinomas and is difficult to evaluate for enhancement in hyperattenuating and densely calcified cysts or other lesions, whereas CT is more appropriate in patients who are unable to comply with breath hold, and it is less susceptible to motion artifact. We've already seen an example where CT was able to better characterize a renal mass which was indeterminate on MRI due to breathing artifact. Here's another example of a patient who underwent renal MRI for a complex cystic mass. We can see that on the axial T2 weighted image, the lesion is complex. It's cystic but also contains a T2 hypointense component. The pre-contrast image set shows that the lesion is not hyperintense, whereas the post-contrast image set suggests internal enhancement. The final image, which is the subtraction image, shows probable enhancement within the lesion, but it's very difficult to definitively characterize due to bad subtraction artifact, as you can see where there is ringing adjacent to the liver edge. The patient underwent a renal mass protocol dual energy CT, and we can see that the image quality is not degraded by motion artifact, and we're able to definitively characterize the internal complex area as enhancing, and this was confidently diagnosed as a Bosniak 3 cyst. A pitfall of CT compared to MRI, which we've discussed, is pseudoenhancement, which is the artificial increase in attenuation comparing pre- and post-contrast images in small endophytic renal cysts due to beam hardening artifact from iodine accumulation in the adjacent kidney. MRI is not susceptible to this artifact and can be used to confirm the absence of enhancement, particularly when pseudoenhancement is suspected, within a renal lesion that is small or endophytic. So we can see here that a hyperdense lesion in the lower pole of the left kidney has increased into the intermediate range on enhanced CT, whereas on MRI, the lesion is homogeneously T2 hypointense, markedly T1 hyperintense, and showing no enhancement on the subtraction images. MRI is also better for characterization of suspected enhancement or possible enhancement in low or non-enhancing papillary renal cell carcinomas. Here we see a mass in the anterior interpolar region of the right kidney, which measures 30 Hounsfield units at unenhanced CT, but appears heterogeneous. It does not increase above 10 Hounsfield units, but due to its heterogeneity, an MRI was performed. We can see on axial T2 weighted MRI that the lesion is very heterogeneous. It does not contain fat or hemorrhage on in and opposed phase images, and it's very difficult to determine whether or not the lesion is enhancing comparing pre and post contrast images. However, when subtraction images are performed, there's clearly a solid enhancing area along the posterior aspect of the mass, which was confirmed as representing a type 2 papillary renal cell carcinoma after surgery. A last advantage of MRI over CT, which was discussed, is in hyperdense or calcified lesions. This is a patient who has a densely calcified right hilar mass, which is impossible to assess for possible enhancement comparing the pre and post contrast images due to the significant amount of calcium. The patient underwent a renal mass protocol MRI, where we can see that on subtraction or on post-contrast images, we're able to see nodular and septal enhancement within the mass, which was diagnosed as a Bosniak 3 cyst. And the enhancement is not perceptible at CT due to the amount of calcification. In terms of new or emerging techniques for CT and MRI, one area that is under active investigation and which has been shown to be particularly valuable is texture analysis of renal masses. Texture analysis uses differences in the grayscale values between pixels within a mass that are not perceptible to the human eye. First or second order texture features can be studied and then applied in various statistical models to determine the ability or the discriminative ability of these radiomic features to differentiate between numerous outcomes. Texture analysis has been consistently shown to be valuable in diagnosis of renal masses in terms of benign versus malignant, clear cell versus non-clear cell, and also to assess for grade amongst the clear cell tumors and other renal cell carcinomas, including papillary and more recently Chromophobe RCC. One paper highlighting the application of texture analysis in renal masses was performed by our group, where we evaluated second-order texture features at unenhanced CT, comparing fat-poor AML and renal cell carcinoma, showing a high discriminative ability and accuracy. The final portion of my talk will evaluate the ability to diagnose and subtype small renal masses with CT and MRI, and also will touch upon the ability to grade the different renal cell carcinoma subtypes. In terms of achieving a diagnosis of solid renal masses, we need to understand what features we are assessing at both CT and MRI. On CT, our tools primarily relate to unenhanced CT density, the presence or absence of calcification, enhancement pattern, necrosis or cystic change, and texture features. On MRI, texture features, necrosis, cystic change, and enhancement pattern remain important variables to assess, but we can also characterize T1 and T2 signal intensity, microscopic fat, and the presence of hemorrhage. Combining these features with the epidemiological factors that we have already discussed can be very accurate for subtyping less than 4 cm solid renal masses. We'll start with fat-poor AML. As we discussed, these tend to occur mainly in young to middle-aged female patients and are discovered incidentally. On CT, they are hyperattenuating due to their smooth muscle content, but unfortunately there is no reliable upper limit that can differentiate fat-poor AML from RCC. Fat-poor AML tend to be very homogeneous at both CT and MRI. They do not calcify or hemorrhage, and they show avid enhancement with washout. Among these features, on MRI, these lesions also tend to be very hypointense on T2 and low on ADC due to their smooth muscle content. And they may show microscopic fat, but this actually occurs in only a minority of cases. It was once thought that the presence of microscopic fat could be a reliable imaging feature to differentiate between fat-poor AML and RCC. However, we now know that this finding is only seen in approximately 1/3 of fat-poor AMLs and is commonly seen in clear cell renal cell carcinomas. So here's a typical example of a fat-poor AML in a young female patient at renal mass protocol CT. The lesion is hyperdense, homogeneous, small, and avidly enhancing. Combined with the young age and the female gender and the absence of hemorrhage or calcification, fat-poor AML should be a consideration in this patient, which was confirmed after surgery. On MRI, we see very similar features in that the lesion is homogeneous, it's dark on ADC and T2 due to the abundant smooth muscle content, and it's avidly enhancing, similar to the renal cortex, and washing out on the delayed phase. So the hypointensity on T2 and avid enhancement suggests a diagnosis of fat-poor AML. Conversely, papillary renal cell carcinomas are hypoenhancing, and this is a characteristic and typical feature of papillary tumors. They can be hyperdense and low on T2, but they can be differentiated from fat-poor AML by their characteristic enhancement pattern. This is the case that I showed earlier, highlighting the potential increased sensitivity for iodine at dual energy CT, and this papillary renal cell carcinoma shows typical features in that it is hyperdense, but it shows wash-in and low enhancement, which is atypical for a fat-poor AML, but characteristic for papillary RCC. At MRI, we see that this papillary renal cell carcinoma is fairly homogeneously dark on T2 and low on ADC. It shows intralesional hemorrhage in that the tumor is hyperintense on T1 and also shows blooming on in-phase compared to opposed phase images due to the presence of hemosiderin and chronic hemorrhage. The lesion is barely enhancing comparing the pre- and post-contrast images, but it is confidently diagnosed as showing low enhancement on subtraction images. So the iso to hypointensity on T2 and the wash-in enhancement can enable a definitive diagnosis of papillary renal cell carcinoma in this patient. Moving on to clear cell RCC, which is the most common and most aggressive of the RCC subtypes. These tumors are avidly enhancing, which overlaps with fat-poor AML. However, they show characteristic features which are not seen in fat-poor AML, in that they tend to be heterogeneous due to the presence of necrosis or internal cystic changes. They're actually iso to hyperintense and not low on T2-weighted signal images as fat-poor AML and papillary RCC are, and as discussed, they may show microscopic fat. This is the case of clear cell renal cell carcinoma that I presented earlier in the dual energy CT section. We can say that this is a more ugly appearing mass compared to the fat-poor AML in that it is larger, has irregular margins, shows internal cystic change or necrosis, and despite the avid enhancement, can be confidently diagnosed as a probable clear cell renal cell carcinoma. The accuracy for diagnosis of clear cell RCC improves on MRI due to the ability to detect internal microscopic fat, which we can see in this clear cell tumor as a signal intensity drop comparing opposed phase to in-phase images. The lesion is iso to hyperintense on T2 and shows a small signal intensity area that is brighter than the cortex. On ADC map, the clear cell renal cell carcinoma is iso to low signal, but not markedly low as papillary or fat-poor AMLs are, and it shows avid enhancement with washout. And these features are fairly characteristic of a clear cell renal cell carcinoma. There is some overlap with Chromophobe RCC and Oncocytomas, which may be collectively referred to as oncocytic neoplasms. It can be difficult to differentiate these tumors from clear cell RCC, and differentiating between oncocytoma and Chromophobe RCC is highly controversial and considered by many not to be possible with conventional imaging techniques. Features on CT that have been described include the presence of a central scar, segmental enhancement inversion, and texture features. However, there is substantial overlap between these groups, and a lack of reproducibility between centers and low inter-observer agreement raise concern for the ability to differentiate between these oncocytic tumors. More recently, several investigators have noted that Chromophobe RCC tends to be lower on T2 and show avid enhancement. So it sort of looks like a papillary RCC that's hyperenhancing, whereas an oncocytoma tends to be brighter on T2 and shows less enhancement than a clear cell RCC. So it sort of looks like an atypical clear cell RCC that shows less enhancement. Here's an example of what I mean by that. In this Chromophobe RCC, we can see that the T2 signal is iso to the cortex, but the lesion is hyperenhancing with washout, which is atypical for a papillary RCC. We might be considering a fat-poor angiomyolipoma, though the lesion is larger than what would be expected. So the possibility of a Chromophobe RCC could be raised, which was confirmed in this patient after partial nephrectomy. Contrast those images with this lesion, which is an oncocytoma. We can see that the signal intensity is much brighter on T2, similar to what we'd expect for clear cell renal cell carcinoma, though the lesion is enhancing less than what we would expect for a clear cell RCC. And in this case, one might consider the diagnosis of oncocytoma, though we certainly could not exclude a clear cell RCC, which would actually be more common. In this case, a diagnosis of renal oncocytoma was confirmed after biopsy. I'm just going to touch on the ability to grade between RCC subtypes. Several studies have shown that it is possible to differentiate between low-grade and high-grade clear cell RCC, type 1 and type 2 papillary RCC, and most recently, low Panner and high Panner grade Chromophobe RCC, though these studies are very preliminary and this type of investigation remains in the experimental phase. So in conclusion, incidental less than 4 centimeter renal lesions are very common, and imaging should and is able to differentiate between benign cysts and solid masses. This distinction hinges on the ability to characterize the presence or absence of enhancement, and it's important to understand the thresholds used to diagnose enhancement at both CT and MRI, and recognize the advantages of limitations of both CT and MRI, and how they may be complementary in renal mass imaging. It's also important to understand the principles and emerging role of texture analysis as the field moves towards radionomic analysis of renal masses. Not all less than 4 centimeter solid renal masses are malignant or behave aggressively. It's critical to understand that approximately 1/5 of these solid masses are actually benign, and that our goal is to try and best identify which of these masses may be benign to prevent unnecessary surgery, if at all possible. Clear cell RCC is the most common and most aggressive RCC subtype, and it's also important for us to try and suggest the diagnosis of clear cell RCC when possible, so that the patient receives the best appropriate management. Lastly, the combination of imaging features on both CT and MRI with epidemiological factors can diagnose a majority of renal mass subtypes and to a lesser extent grade renal cell carcinomas in less than 4 centimeter renal masses. However, these features require multi-center validation studies in order to confirm reproducibility and accuracy. Thank you for your attention, and I hope that you found the lecture helpful.